Attendees are in listen-only mode.
Focusing on the consultation on the MRFF strategy and priorities. My name's Greg Mullins. I've been Head of Policy at Research Australia since 2012. On your screen you should be able to see the title screen for this presentation. You should also be able to see the go-to webinar taskbar. While you can hear me, I can't hear you, but you can use the taskbar to type questions, and I'll endeavour to answer these as we go along or at the end. I've been involved with the MRFF from its first announcement in May 2014, including watching the initial debates and controversy, the evolution of the bill and the negotiations in the Senate. More recently, I've been in contact with the bureaucrats in the Department of Health responsible for compiling and circulating the consultation paper. The MRFF is a great opportunity to improve the health and well-being of Australians. It has significant implications for how we fund, conduct and translate health and medical research in Australia. It is critical that as a sector we engage with this consultation process. The aim of today is to assist with making submissions to the consultation and addressing the consultation question. Today I'll provide a brief overview of the MRFF. We'll also look at what the strategy and priorities are and the role they play in relation to decisions about funding. And then we'll look at the specific questions being asked in the consultation. You should have a copy of the paper calling for submissions and the templates responding to the strategy and priorities. If you don't have it, just Google MRFF consultation. You'll end up on the website address shown here on this slide. First, a quick timeline. The MRFF was announced in the 2014 budget. The legislation to establish the MRFF was passed last year, following negotiations in the Senate with the Greens. Research Australia was actively involved, including making submissions to the Senate and attending the Senate inquiry hearings, and the legislation changed quite a bit through this process. Research Australia also conducted an extensive consultation with our members over several months last year, including forums, a survey and one-on-one interviews. This has informed the work Research Australia is doing on the MRFF, including our response to the consultation on the strategy and priorities. I'm sorry, I think there might just have been a problem, a technical problem. I might just go back to the previous slide quickly. So this was the introduction slide, and that's the paper that I was referring to there, the call for submissions. So coming back to the MRFF and the timeline, so as I was saying, the MRFF currently has a balance of $3 billion, and it's the investment earnings on this amount that's providing the annual funding. And the first funding of $61 million is expected to be available in the next financial year. The government's intention is to keep the balance, to keep adding to the capital of the fund each year until it reaches a balance of $20 billion, which is currently projected to occur in 2021-22. As the balance of the capital in the fund grows each year, so does the amount of investment earnings available as funding. This is expected to reach $1 billion per annum in 2022-23. There's nothing magical about this figure. It simply assumes net earnings of $5 billion, of 5%, on $20 billion. The investment's managed by the Future Fund Board of Guardians. This board's responsible for the investment of a number of future funds on behalf of the government, and their track record on investment to date has been good. So the MRFF is to provide funding for medical research and medical innovation, and the definitions from the Act are shown on the screen. While the legislation refers to medical research, the definition makes it clear that this includes health research, and that was a change that was made early to allay some concerns about the way it was being expressed. The definition of medical innovation was amended in the Senate also to make it clear that it included both commercial and non-commercial translation. I think it's important not to think of the MRFF as funding either research or innovation, not two different streams of funding. The opportunity here is to fund initiatives that undertake both research and innovation, i.e. to provide funding that carries through the research stage and into translation, either through supporting the commercial development of a product or the non-commercial translation of evidence into practice or a change in government policy. I don't want to overdo the comparisons with the NHMRC, but I think a few are constructive. One of the key differences is that the NHMRC's legislation requires it to fund research and research training, while the MRFF is to fund medical innovation and medical research. This difference is worth thinking about when considering what the MRFF should provide funding for. And the legislation specifies the types of organisations that can be funded. The ability to fund states and territories through the COAG Reform Fund reflects, I think, the desire to engage and work with the states and recognising, I guess, that they provide much of the healthcare system in Australia. And funding can be provided to corporate Commonwealth entities like the CSIRO, which already undertakes quite a lot of medical research. Corporations has a wide meaning and encompasses private sector companies as well as most not-for-profit organisations. And while some people have criticised the lack of a reference to hospitals, funding can be provided to hospitals via the states and territories or in many cases as corporations. This range of organisations that can be funded, I think, highlights a key difference with the NHMRC and ARC on the one hand, and also with the industry funders for industry-focused programs that are provided by the Department of Industry. And I think the MRFF provides a real opportunity to bridge the gap between publicly funded research organisations, the health system and the private sector through funding collaborations of partners across these areas in ways that aren't really currently possible. And for organisations used to bidding for NHMRC and ARC funding, this means more competitors for MRFF funding, but also potentially more collaborators as well. Funding decisions are made by the Health Minister. There's no intention to create a new NHMRC or ARC to administer and decide funding applications, although the Minister can draw on the services of the NHMRC and other agencies where appropriate. The Minister can also delegate decision making to the Department and or to the NHMRC CEO. And the Minister's decisions have to be in accordance with the strategy and priorities, and which are determined by the MRFF Advisory Board. The appointments to the Advisory Board were announced on the 4th of April this year, and the Board as a whole is required to have expertise in medical research, policy relating to health systems, management or delivery of health services, medical innovation, financing and investment, commercialisation, philanthropy, and consumer issues relating to health. Professor Ian Fraser is the chair. The MRFF Act also requires the NHMRC CEO to be on the board, and Professor Anne Kelso has been appointed. Yasser Al-Ansari brings financing, investment and commercialisation expertise from his role as CEO for AVCAL. And Jennifer Williams has experience in delivering health services, has worked in a range of different hospitals and health service environments. Dr. Rathjen brings experience in medical research, innovation and commercialisation, while Professor Reynolds has expertise in research and innovation in medical devices. And Professor Hilton brings experience in medical research, as does Professor Hodge. I guess harking back to the list of attributes on the MRFF legislation, there's no apparent expertise though in philanthropy or in consumer issues, even though there are a couple of listed items. There's also no clinician researcher. Apart from establishing the strategy and priorities, the Board will advise the Health Minister when advice is sought. And the Board must undertake the consultation on the strategy and priorities, which is occurring now. It's not clear how often the Board will meet in between reviewing and renewing the strategy and priorities every couple of years. As noted earlier, the Advisory Board is responsible for developing the 5-year strategy. There's little guidance and even fewer restrictions in the legislation, simply that the purpose of the strategy is to ensure a coherent, and consistent approach to funding. The Advisory Board is required to consider the NHMRC strategy, which will no doubt be assisted by the presence of the NHMRC CEO on the board. The strategy can't require payment to a specific individual or to a specific project. The quote from the department that you can see there was in response to some questions I asked about the differences between the strategy and priorities. It emphasises addressing gaps in current funding, driving alignment and coordination across the sector, and linking research to the health system.
No? I think your government was around here.
The gaps in current funding is likely to focus on the gaps between research and translation, I think. One way to differentiate the strategy and the priorities is to think of the strategy as the how and the priorities as the what. For example, the strategy should consider how funding will be provided, how research and innovation should be undertaken, and how it will be measured and evaluated. Research Australia's own submission is emphasising a focus on collaborative, multidisciplinary research, with a focus on delivering better health outcomes.
Yes.
Collaborations between and with researchers, clinicians, healthcare organisations and the private sector are to be promoted. It's about the types of programs that could be funded and the types of outcomes they could be funded to deliver. Funding of indirect costs is also a potential consideration here, and I think it's worthwhile considering whether they should be funded by the MRFF or whether research organisations should be seeking to rely on existing indirect cost funding programs. There's more guidance to the Advisory Board around the priorities. The legislation requires the priorities to be consistent with the MRFF strategy. More helpfully, it requires the Board to take into account the burden of disease, providing practical benefits to as many Australians as possible, and providing value for Australians. It also needs to do this by providing funding that complements and enhances existing funding.
I'll be here.
So not just more of the same. It's probably not worth suggesting just adding the funding to the pool for NHMRC project grants, for example. The response from the department makes it clear that the priorities are more specific than the strategy, but frankly it's not really clear where the line is between the two. While the MRFF Act prevents the Advisory Board from providing specific recommendations about who and what should be funded in the strategy, the same prohibition doesn't apply to the priorities. $61 million is expected to be available in 2016-17 and $120 million available in 2017-18, the period of the first two-year priorities. It's not exactly a small amount of money initially, but it is set to increase rapidly if the MRFF goes to plan. One question to consider, I think, is what's important to fund in the first 2 years as the MRFF becomes established. This brings us to the consultation process. It's tightly managed and timelines are short. I suspect they're expecting a lot of submissions. There are specific questions that responses to the consultation are expected to address and strict word limits. The initial open consultation process will be followed by a targeted consultation process in July. And it's not clear when the strategy and priorities will be provided to the Minister or how soon the first funding decisions will be made. You can make a submission on one or both, and the pro formas for doing this are on the website. The text you can see on the screen here is the text from the pro forma for submissions on the strategy. As noted earlier, I think the strategy is about the how rather than the what. The sorts of questions I think it's trying to address are, what are the barriers to the performance of research and innovation in Australia? What prevents research being undertaken? What prevents research being implemented? And how can these be overcome? And you can see there's a requirement there to address a specific gap, to come up with a solution, to talk about how you'd measure success. And I think it's important to fit these to the building blocks diagram, which is actually providing the consultation paper, and which is on the next slide. This is the building blocks diagram from the consultation paper. And I think it's important, as I said, to be guided by this as to the gaps, i.e. the challenges and what you're trying to achieve. For example, if you thought the problem is the failure to implement evidence-based research in clinical practice, you could use the first challenge in the top left corner to frame the gap as the failure to facilitate the translation of research into health outcomes. Or it could be the second from the left, the failure to embed research in the health system due to a lack of interaction between researchers and clinicians, and few incentives to implement evidence-based practice. Perhaps it's both. To address this, you might then propose funding programs that require partnerships between researchers and one or more health institutions, where the institution has identified the problem and given a commitment to supporting the research and implementing solutions. Looking to the second row of the diagram, this fits with the aims and objectives of leveraging and enhancing collaboration and integration, also with a translation pathway that maximises opportunities for success, and at least a couple more. It also ticks the box in terms of delivering practical benefits in row 3 and includes several of the stakeholders listed in the bottom row. I think it's sensible to stick as closely as you can to the building blocks diagram in making your submissions. The pro forma on the priorities is more detailed, and it has 7 questions in total, and the first 2 of them are shown here on this slide. You're allowed just 1 sentence on each, so you need to keep it short. As for the strategies, I think it's worthwhile looking to the challenges identified in the building blocks diagram to help you word your responses. It's worth remembering that when the challenges refer to the translation, this includes commercial and non-commercial translation. This is the third question, so you're being asked to comment on the aims and objectives. And again, remember that the aims and objectives are outlined in the building blocks diagram, and there are a range of options here. So prevention and cure, a better performing workforce, more cost-effective healthcare, better research infrastructure, economic benefits. So it's likely that there's going to be an aim or objective there that's going to fit with the priority that you're proposing. This question of mandatory considerations. So these are the matters that are set out in the MRFF Act that the Advisory Board must consider when developing the priorities. So I think you have to ask yourself, does your priority help address the burden of disease? Does it deliver practical benefits such as improving the quality of care in hospitals or preventing illness? Does it lead to economic benefits through exports and licensing of commercial products, or reducing the cost of healthcare and making the system more efficient, or replacing the existing more expensive practice? The last one there, about how to ensure that disbursements complement and enhance other assistance, is a little more problematic. It can't just supplement existing programs. It's pretty clear from this. So if we take the ARC linkage program, for example, the ARC won't fund linkage projects for medical and dental research, and there have been calls in the past for the scheme to be open to health and medical research. Research Australia is going to be recommending an ARC linkage stream funded by the MRFF. We're arguing that it complements and enhances the existing ARC linkage scheme because it's not currently open to medical research and innovation, and it enhances existing funding because such a scheme would support translation and research in a way that's not currently available. I think that's an example of how you can use the priorities to put forward a proposal that perhaps looks similar to some of the existing proposals, but can still be argued as actually complementing it and enhancing it rather than just supplementing it or duplicating. So the outline of your priority proposal is where the bulk of your 3 pages are presumably going to go. The notes on this section say, provide this in as much detail as possible, including the proposed solutions to the gaps and challenges identified in responses 1 to 4, the barriers to success that funding would overcome, implementation feasibility, and risk and management strategies. What you can see on the screen there is another quote from the Department of Health. And this raises the question of how specific you should be. The MRFF Act says the strategy can't direct funding to individuals or projects, but there's no such restriction on the priorities. And the advice from the department here is clear, sort of. Not specific disease burdens. You can't propose a specific disease burden as a priority area. That seems to blur the line, I think, between the strategy and priority. I think this example here highlights the question about how specific you should be. So let's assume you decide that increasing capacity in health services research should be a priority. Relating it to the building blocks diagram, this works to the challenge of continuous improvement and efficiency in healthcare delivery and to the aims and objectives of a balanced and appropriately skilled workforce. So you could propose the creation of an Institute of Health Services Research. This is in fact a McKeon review recommendation for addressing this issue, or perhaps even a virtual national institute. You could go even further and propose that the MRFF fund University X to establish this institute. And it's really not clear how far you should go in terms of putting forward a proposal for a priority, even though the department has said it doesn't want individual research projects. I suspect there's probably no harm in being specific, but I would suggest that you work from the more general to the specific, so the argument stacks up at all three levels. So explain why there's a need for greater capacity in health services research, also explain why you think an institute is the best way to build this capacity, and then why University X is best placed to provide this institute. So these are the next couple of questions you're being asked to address in respect to the priorities. So they're clearly looking for KPIs and measures of success. And this has a translation focus with the impact on consumers. But there are numerous ways this can be done. So for example, you might be talking about population effects, mortality, morbidity, prevalence of disease. You might be looking at system impact, so quicker and more complete adoption of evidence-based practice. It's worth remembering they want these in dot point, so you're not going to have a lot of room. It's probably also worth remembering the well-known SMART principle. So be specific, targeting a specific area for improvement, be measurable, quantify or at least suggest an indicator of progress, assignable, so specify who's going to do it, be realistic, state what results can realistically be achieved given the resources you've got, and time related. You need to specify the results and when they can be achieved. The question of linkages, which is raised here, again I think you should refer to the building blocks diagram. For example, taking the linkage grant proposal given earlier, the ARC would be a stakeholder, or maybe you're proposing joint funding programs with international agencies. Stakeholders could be state governments, other Commonwealth departments, hospitals, and policy agendas could include proposals to better address care for patients with chronic disease, further reduce rates of smoking, etc. The priorities template only caters for one priority, but you can submit more than one. So there's no need to prioritise one great idea over another. But you do need to be conscious that it is only 3 pages and it's 11-point font and 6 June is not far away. This is really the end of my presentation. I'm not sure whether anyone has any questions or has had a chance yet to type them in. We might pause for a minute or so and give people a chance to do that. I don't have any questions coming through, so I don't know whether that's because this has all been entirely clear or people have got, managed to completely bamboozle them. Look, good luck to all, and I hope this presentation was helpful. There's a very brief survey to complete at the conclusion, and it'd be great if you could take the time to do that. And if you'd like to follow up on any of this, or you come up with any questions later, please call or email me. Let's give people... Okay, we do have some questions coming through. I'll just turn to those now. I do have a question about whether the priorities that we submit should be costed. It's not something they've specifically made provision for in the template. So you'd think if it was something they specifically wanted, they would have done that. I don't think there's any harm though in being as specific as possible. The failure to include that probably reflects the fact that they're not looking for things that are specifically project type proposals. I'm just going through some of the other questions I've got here now. I've got a question about how interested the MRFF Advisory Board is in ensuring a consumer focus in research. I think the fact that there hasn't been a specific consumer rep appointed to the board, I mean, that's a decision more by the Minister than by the Advisory Board. I think when you do look at the people that are on the board, people like the Chair, for example, and certainly Professor Kelso, I think there will be an emphasis on a consumer focus. And in a lot of ways that's driven by the legislature. When you look at it talking about the need for example, for practical benefits and delivering value to the community. But we will have to wait, I think, and see how that's picked up in the strategy itself. There's a question here about whether for disease-specific organisations we're suggesting that we don't focus on the specific disease. And I'm not suggesting that, notwithstanding what the department said about not wanting priorities that are disease-related. I personally can't see any reason why, in terms of the priorities, you couldn't nominate an area like that. And it may be that that's not what they're expecting to see, but if they are getting those sort of outcomes through, that will potentially influence the priorities. So I really don't think that suggestion that you shouldn't propose specific diseases should prevent you putting in a priority like that, particularly if you think very strongly about that. So I'm just clicking through questions. One of them here is there's a repeated emphasis on benefits to all Australians, and does this detract from a submission focusing on rural or remote Australians? I don't think it does at all. I think there's certainly scope to do that. It would fall into that space, again, of providing practical benefits and also providing value. So I think it's really a case of making the argument for why specific communities and specific diseases should be considered. I've also got a question about whether this consultation is the only avenue for input. At this stage, this is the open stage of the consultation, and the board has indicated that there will be a targeted consultation conducted in July. So I think the plan is actually to get the responses in that are received via this open one by the 6th of June, probably to have a look at those and then look at the groups that they need to follow up with and specifically any people they think that haven't been represented. I've I've got a question about whether if a grant proposal's already been submitted on a specific area, should it still be submitted into this process? And again, I think the answer is yes. It's very difficult to know exactly how the proposal is going to be considered, or even exactly how many they'll be receiving. But I can't see any harm at all in lodging applications. And certainly, coming back to that question before about burden of disease, when you've got one of the areas that's being nominated for burden of disease is one of the things that's nominated for consideration in the priorities is burden of disease, then it would certainly seem to suggest that you could be nominating specific disease areas. There's a question about whether submissions can come from individuals or whether it's best to do it at a department or institution level. There's certainly nothing in the consultation process that prevents individuals making those submissions or that places limits on who can or can't do it. You probably need to consider your own institutional policy and what's required, for example, for you to be able to make a submission that was put forward as representing the views of your institution as opposed to your personal views. Also have a question here about if the proposal is a collaborative one, should one or more of the partners submit? I think one of the key things about the Medical Research Future Fund is that ability for funding to be provided to a range of different organisations, so to universities, for example, but also to private corporations. So where there might have been a practice in the past, particularly with the NHMRC, for one organisation to take the lead on the application, and perhaps because it was an administering institution, I think that restriction's going to be removed with the MRFF, and you'll actually have a scope for collaborative applications from a range of organisations where they effectively all can be submitting as equal partners, and you won't need, for example, a lead applicant just because that's the only organisation that would be eligible to directly receive the funding. Research Australia itself will be submitting proposals both in relation to the strategy and the priorities, and we are in the process of developing those up at the moment. I think like everyone else, we're working hard to meet the 6 June target. I've had a couple of people asking whether the presentation can be made available, and we will do that. I'll make that available on our website, so if you want to come back to our website later today, it will be available there. We'll also try and get an email out to everyone that's attended with the link to that. So I've got a specific question here about whether a priority submission could be put in jointly between an NFP corporation and a research institute. I think the answer is yes. I must admit I haven't yet tried going in and electronically submitting an application. I think you might have to nominate one organisation to do that, but there would certainly be scope to indicate that the priority submission was being proposed by or in conjunction with another organisation. It might even be best for both of them to actually lodge the same submission. There's a question here about whether it's going to be possible to present priorities in one-on-one consultations if a submission on priorities isn't made as part of the open consultation. At the moment, there's no indication that that's going to occur, other than that there's going to be a targeted consultation. Now, the targeted consultation suggests that that's going to be by invitation only, but there would be scope, presumably, to approach them and ask for the opportunity to talk about a specific proposal in more detail, and you may or may not, I guess, get agreement from the advisory board to do that. It's probably just worth making the point that, as I've said a couple of times during this, the Department of Health were happy to ask some questions, answer questions that we had around the priorities, and it provided further information. So they're certainly engaged with the process and are looking to try and make it as easy as possible for people. I've got a question about whether the priorities inform the strategy and whether a strategy submission can be put in by itself. I think the answer is absolutely yes. In fact, it's probably more the case that the strategy informs the priorities. And it's certainly possible to make a submission on the strategy and not on the priorities, and vice versa as well. So the way the pro formas are structured, the two of them stand quite separately. I suspect for many organisations they'll be thinking about the strategy and then identifying priorities that would help to implement that strategy, but it's not actually a requirement of the process to take that approach. I think I've covered the questions I've received today. I'll give people some more time to post some more questions. Or if in fact you think you posted a question I haven't answered, you might want to post it again. I have a question about whether Research Australia plans to share its submission with members prior to June 6. We, at this stage, have some material already. I have to be honest and say at this point we haven't made our submissions and we'll be working to that June 6 deadline like everyone else. If possible, we will share them, but it may be that by the time we go through our own internal sign-off processes that we are very close to that June 6 deadline and aren't in a position to share those specific submissions. We do have a larger document which came out of the consultation process that we conducted last year, and we will be looking to make that available. But again, I'm not sure that it will be available prior to the 6th of June. I'll certainly let people know when it is. Okay, I haven't received any more questions, so I might just give another 10 or 15 seconds. If we don't get any more coming through, we might wind it up. Okay, look, thank you for attending, and I hope that this has been helpful. We will make the presentation available on our website, and so that will be up later today. If you want to come back to the website, we'll make sure we've got a prominent link to it, and I will also try and get an email out to everyone, including the link to the presentation. As I said before, if you do have any further questions, please feel free to email me or give me a call after this. Thank you.